you subdivide into those of the lower esophagus, upper stomach, so people with a wide crura, fundus in the hiatus hernia, a weak sphincter, or migration of the sleeve itself. Or it can be those of a distal or flow problem. So you've got a high pressure or low compliance system, there's narrowing or stricture, or a kink. So let's go on. So where's the evidence for there actually being reflux after a sleeve gastrectomy? So this systematic review and meta-analysis looked at sleeve gastrectomies and looked at 24-hour pH studies after a sleeve. And if you look at Gorodner et al. In the first study, they had 14 patients and they found that the actual acid exposure in the distal esophagus increased by 102%, and that the DMISTA score increased by 125%, and de novo reflux was found in an increase in 36% of patients. Rebecca et al. Then looked at patients who didn't have reflux prior to their sleeve gastrectomy and those who did. In 37 out of 65 patients who had no reflux, there was a 9.4% increase in the acid exposure, in the total acid exposure in the distal esophagus after a sleeve gastrectomy, and 10.8% of people who developed de novo reflux. And in those who did have reflux, they actually found a relative difference, as in a reduction in the pH acid exposure in the distal sleeve, which is contradictory. So, the evidence is either way in the literature. And this is quite a busy slide. And I think for you to concentrate is on the red, green, and the yellow boxes. So this looks at the lower esophageal sphincter pressure, and Brighetto et al. Found that actually the lower esophageal sphincter pressure after a sleeve gastrectomy reduced from anywhere between 26% to 39%. And Rebecca found actually there's no difference. And paradoxically, if you look at the yellow boxes, some people actually found that the lower esophageal sphincter pressure actually increases after sleeve. So there you go. So it's difficult to say, but I'd say it's safe to say it probably is reduced. And these are the manometric changes by Brighetto's original study. So we know there's a problem distally or higher up at the lower esophageal sphincter. So how do we go about augmenting the lower esophageal sphincter? Now, if a patient has a hiatus hernia within a fundus, for example, then it's quite simple. You have to go fix it. You have to do cruroplasty. So that's like a given. So I'm not going to go into all that and the evidence for that, because I think you'd be silly not to do that. But I'm just looking at some other technologies that we use at George's and whether it could be used in bariatric patients and the evidence for it. So the first device I'm going to talk about is the LIBBS device. Now, there's a video here, see if I can play it. And this is actually LIBBS being put in. Okay. So the LIBBS, it's basically a metallic magnetic device which augments the lower esophageal sphincter. It's meant to be good in the sense that it preserves your normal physiology. Okay, so people can swallow, belch, and vomit after the procedure. Okay? So actually, a lot of people, this is done at the day case in our centre, and it is reversible. But you must be aware that the actual LIBBS device can encapsulate, so it's not so easy to take out, as they say. And it's important to spare the vagus nerve, and it's outside of the LIBBS device, otherwise patients get quite a few symptoms. Okay. So what's the evidence for the LIBBS device? So here, again, we've got another systematic review. And in this systematic review, this is the LIBBS device after bariatric surgery, and they identified 33 patients. And in these patients, predominantly had a sleeve gastrectomy, which led to reflux. And in this, it's important to understand that 43% of these people had basically a cruroplasty to basically reinforce the crura, and most people were done as day case and discharged day one post-op. And in this study, they found if you look at the health-related quality of life scores after a LIBBS with regard to GERD, there's an improvement in all the studies. So that's quite important to see. The other important thing of the study is a third of the people actually continued to have reflux, and a fifth of people developed de novo reflux. So that's also very important. And furthermore, studies with the larger numbers in them, they actually found that 5 patients developed dysphagia, for which 3 people had a dilatation and 2 people had removal of their links. So a more recent study in 2019 by Broderick et al. Showed that putting links for bariatric surgery for refractory GERD 8 patients, these were 13 patients in all, 8 had a sleeve gastrectomy, 4 had a Roux-en-Y, 1 with a duodenal switch, predominantly female with good weight loss after their bariatric surgery. Their pre-op Bariatric score was 24, so after their bariatric operation. And post-operatively after links, 9 out of 13, so 75% of patients were off PPIs at about 16 months or so follow-up. Longest follow-up was about 38 months in this particular study. And their health-related quality of life scores improved from 25 to 8.5, which was significant, 2 patients getting dysphagia. So promising, potentially. And the next device I'm going to talk about is the Sphincter. I don't know if anyone's had experience with this, but it's something we do. And Sphincter is basically an endoscopic procedure done as a day case under a general anesthetic. And what it involves is basically a thermocoupled controlled radiofrequency ablation through the scope to the above, at, and below the GOJ at 6 points. And it can be done in about an hour, and it's placed through a balloon-guided catheter with 4 electrodes sort of perpendicular to each other, and then you give heat energy at a given temperature for a predetermined time. And that augments your lower esophageal sphincter. If you ask anyone how it works, I don't think anyone really knows, but the thermal energies tends to do the job. So that was a video. Okay, so now, initial studies by Matter et al., this is Phil Schauer's group, and they looked at people with refractory reflux after a bypass, and that's up to, I think, 20% of patients. I mean, some people even say 50, but I think that's a little bit high, but I'd say 20%. They had 6 patients who had a Roux-en-Y gastric bypass. They did a Bravo study, which is a 48-hour capsule endoscopy, and DeMister scores in these subset of patients reduced from 35 to 14, and the fraction time in which the pH is less than 4 went from 7% to 3%. So, again, quite promising results. Then, what happens in sleeve gastrectomies? So, this study by Kadira et al. Had 15 patients post-laparoscopic sleeve gastrectomy who had refractory GERD. Sphincter was performed at about 24 plus or minus 18 months in these patients. Of these patients, they all had manometry studies. Well, 14 out of 15 had manometry studies, which showed a hypotensive sphincter. 2 patients had a hiatus hernia on barium swallow, which was not fixed at the time, but they were quite small. And the DeMister score, a mean DeMister score was 27.9. And they had their excess weight loss was about 44 plus or minus 21%. So not bad weight loss. So what did this study show in the sleeve patients? Well, if you looked at their GERD symptoms and quality of life scores at 6 months, unfortunately, there was no change. Okay. So let's go to what most of us consider the gold standard operation. So you basically have a bypass procedure or a drainage procedure of the sleeve. So I think this is fairly solid evidence and what most people would do. So this is a Canadian experience of 273 patients who had a sleeve gastrectomy. 6.6% of whom were converted to a Roux-en-Y bypass, 26% for reflux, and 65% for inadequate weight loss. And the resolution of GERD was up to 75% in these patients, so it seems to do the trick. The weight loss was about 23 plus or minus 18.2 kilograms, which I think clinically is significant, however, statistically was not significant. Another study, the sleeve gastrectomy, converted to a Roux-en-Y gastric bypass in 22 patients, and this is by actually Litchett and Palmer's group, who's probably in the audience, and this actually showed in 24 patients who were converted from sleeve to bypass, 50% for inadequate weight loss and 46% for GERD. They showed 100% improvement in GERD, and 80% of patients were off PPIs. However, the actual overall weight loss wasn't significant after a bypass. So now let's look at other things. So I don't know if you've heard of the sort of fundoplicated sleeve or the Rossetti sleeve. So I think there's a group in Italy that do it, or a couple of groups in Italy. There's a group in Montpellier, I've just been told to do it, and the Chileans do it as well. And it's basically a sleeve gastrectomy, but a modification of the sleeve gastrectomy in which you leave a very small fraction of the fundus, obviously not a large amount, because it defeats the purpose of a sleeve gastrectomy without the actual stitch to the esophagus, unlike a normal Nissen's, and just one stitch, gastrogastric stitch. So there's a possibility of telescoping, I suspect, and that's a picture of it there. So what did they show? So this study by the Italians showed in 40 patients, all patients with GERD, either shown endoscopically or via pH studies, BMIs of 44 plus or minus 4.7, 25 of whom had hiatus hernias, which were repaired, and an average DMISA score of 26.5. They found that actually that the percentage excess weight loss was really good. At 12 months, they had 61.7%, plus or minus 13. They found that GERD symptoms had improved in 95% of patients at 12 months. And actually, endoscopic lesions had halved in this patient group also. So potentially there's some promise there. And so in conclusion, I think looking at this evidence, the gold standard is still a drainage procedure. The links potentially may show some promise, but it's yet to be tested to its full. Stretta, I think, works well in possibly low pressure systems, but and augments the lower esophageal sphincter to a lower degree than something like the links or a fundoplication, but it's unlikely to work in a high pressure system. I don't think there's a role for it in the sleeve, to be honest with you. But obviously it means no dysphagia unlike the others. And then there are other technologies, and I think it's endoscopy is improving, such as GERD-X, for example, EasyFix, and like, for example, the sleeve Rossetti fundoplication. So, there's all these options to go for. And that's it. Thank you very much.
Thank you. It was a great presentation, and you went through it systematically. The key is to kind of hopefully prevent reflux after sleeve gastrectomy. Yeah. Are there any predictors? When you ask patient history, medication history, is there anything more you could do to hopefully prevent the situation?
I think that's what everyone's sort of searching for, isn't it? I mean, I don't know my experience what those things are, to be honest with you, because I think it's very unpredictable. I think when you do the operation, if you find something, I think you should fix the anatomy. And
is there a role for preoperative endoscopy as an investigation?
To be honest with you, I don't think so. I mean, if you do it, then you just do everyone, but I think that's quite an expensive thing to do. And you may do things you may not need to do as the patient's asymptomatic.
Thank you. Dr. Agrawal.
Excellent talk. But the fact that only 4% of patients require a revision, that means most of patients have a mild to moderate reflux.
Yeah.
So what do you suggest we do? What are the strategies to, tackle that big cohort of patients which has this mild to moderate reflux?
I think
only very few patients who have severe.
Yeah, no, I agree. I agree. Yeah, I mean, I think you give them medication, see how they get on. Like you said, I think you mentioned surveillance at 5 years. That's what you do in your unit. Is that right? Or?
I think what I was looking at is the eating behavior modification.
Yeah, of course.
So a lot of them eat fast.
Uh-huh.
That's one of the mechanisms. Yeah. And a lot of times the reflux symptoms are not actually reflux. It's basically food intolerance and other things.
Yeah, sure.
So I think it needs a detailed evaluation and just saying that it's reflux. Mm-hmm. And then eating behavior modification is an important part of the whole treatment strategy.
Yeah, sure. Slope?
Yeah. So it's interesting. Most of us actually do that sleep to Roux-en-Y for reflux. Probably it's one of the problems we've seen them do. It's quite impressive that they had 100% improvement in sleep in reflux when they did a Roux-en-Y. Did these patients have a hiatus hernia pre-operative, or did they have a hiatus hernia that we gave them post-operative?
Which study are you talking about? Sorry, I've how do I get rid of this?
There are 4 anterior choroplastics, which they mentioned. They mentioned 4 anterior choroplastics, and they did not put up.
There you go.
In the central paper.
No, we're not talking about central paper. We're talking about the other one, the conversion to Roux-en-Y.
Which the Canadian experience then?
It was Canadian.
Yeah, it must be the Canadian one.
Okay, question from here, from front.
Yes, so for people with mild to moderate reflux, 70% of reflux episodes are caused by transient lower esophageal sphincter relaxations, which are triggered by fundal distension, usually with gas. My experience of the sleeve is actually it improves mild to moderate reflux in most people. Yeah. I think it does that by decreasing the amount of transient lower esophageal sphincter relaxations. There's no evidence of that. You need to actually measure it with a dense sleeve. But I think that there's a lot of misconception about reflux and sleeves. One of the problems is that there's a crossover in reflux symptoms and symptoms after a sleeve. So many people who eat viscous food after a sleeve will experience dysphagia or retrosternal discomfort. And the doctor may misinterpret this as symptoms of reflux. So I think there's a lot of misunderstanding of reflux and sleeve.
I don't think it's very clear cut. I agree.
One final question, Ashok.
Oh, that was a very good presentation. Just regarding the LIBBS system, one of the concerns with the previous generation of similar devices, magnetic sphincter augmentation, the angiogenesis system, the level of erosions and complications that we get afterwards. Now, obviously, the LIBBS, people have done studies and have shown that rate of erosion is comparatively low. However, are you aware of any evidence of what the erosion risk is like when this has been inserted in post-bariatric patients?
No. In none of the studies identified there's not been erosion in any of them. And even in primary, I don't think there's been any erosions in any published literature.
Thank you. We're going to move on. Well done.